Thank you so much to Nick and to all the speakers. I'm conscious of time, so I'll quickly try and summarize and then frame the discussion, and then I'll turn it over to the group. So we need scalability to allow access to mental health interventions of a psychological nature. We can't reach everybody who needs help with the existing paradigm of face-to-face therapy, which is effective, but not necessarily accessible. And these scalable digital mental health interventions need to be personalized. And so I think when we reflect on what we're doing in personalization and the approaches that we're taking, we want to think about, how does therapy work? What is it about therapy that is effective? And so we're working on a measurement paper, and you could kind of conceptualize face-to-face therapy as teaching skills, which we heard a lot about today, delivering psychoeducation, and then having some non-specific elements. There are certainly other things, but this would be one way to think about it. And it can be a dynamic process, but there's a directionality of these effects. And so you're delivering some piece of information, and then the user or the client is receiving that, and then they have to apply it in their daily lives. And so, thinking about how that works inside the session, outside of the session, as they're going home and practicing and implementing these things, there's a wide variety of places in which personalization can improve this. And so I think we want to think about, is what we're trying to do with personalization just make a better therapy, a better digital therapy, or is it actually trying to personalize it, to match it in a way, right? So it could be that just the sort of personalization that we're doing just makes it better. It's more engaging for everybody. Or it could be that person A, because of their unique features, needs this thing, and person B needs something else. And those are going to have two different sets of things to think about. So what I'd love to hear the speakers share their wisdom and insight on are a set of questions about, how do you think about, what are the goals of the personalization that you're doing? Are you trying to increase engagement? Are you trying to match people to techniques? Are you trying to reduce the burden of self-report? Are you trying to make the intervention more dynamic in terms of just-in-time adaptive interventions? Are you trying to make it stickier or more memorable? What is it that you're trying to do? And how does that guide how you approach the personalization? And then based on that, what are the types of data that you need, right? Because if you're trying to match people to treatment, you need to know, what are the differential effects of this versus that for a person who has these features? Whereas if you're trying to drive engagement, it may be that other things can inform that. And so you have very different sort of data requirements there. And I think that the data needs for these different approaches can really guide what we can do. So if we need thousands of people, or as we've seen with some of these talks, if we need corpuses of highly curated data, and if using some of the sort of low-hanging fruit creates a model that doesn't work, how do we think about that, and kind of what the role of the data requirements is? And then finally, kind of what are the ways in which you instantiate that personalization? Is it an algorithmic model? Is it a statistical model? Is it a more sort of like decision tree? And we've seen so many great examples of it. So I will now shut up and really look forward to hearing everybody's thoughts on these or anything else.
That was a lot of questions. So I'll just go ahead and get started on a couple of thoughts that came up. One is I think the framing of what you're saying. I would delivering psychotherapy via digital tools. I would take a little bit of an issue with that. That is, I think psychotherapy is great, but when we're delivering these tools, we should not be constrained by psychotherapy. I think what we as behavioral scientists have that we can bring to it is a lot of knowledge about from behavioral science, kind of what kinds of strategies work, but not psychotherapy models. I think we need to step back, and there may be a lot when we start engaging in the context of people's lives. there may be a lot of opportunities that we haven't had in face-to-face interventions. And I'll give you one example that just was sort of illuminating. A year or two ago, we did a study that where we basically had people give little short video, like 30-second video, send them on little video journeys to tell us what's bothering you, how did you manage it, et cetera. And one of the things that was really interesting, it was a small sample, but about a third of the people talked about their pets. And they talked about using their pets, that they don't want to, they try to not be anxious because it makes their dog anxious. That pets were a huge part of their management of their mental health problems. And I thought, this is really weird, So I talked to a veterinarian, like, that I know, and said, is this a thing that, that pets get anxious? And he said, oh yeah, if somebody brings a dog in, I can tell you whether that person's depressed, or whether the owner is depressed or anxious. So there's, that's one example of something that we never even think about as therapists, because we don't interact with their pets, but there's an opportunity for engagement. So I think we need to kind of step back from psychotherapy and think about digital interventions as a new form of intervention that uses our principles, but not necessarily all of our methods.
I just want to second. Oh, sorry. I want to kind of second that. And I am a psychotherapy treatment researcher primarily. So I feel like I've had that learning curve happen myself, where I initially sort of approached these things of let's take a therapy and kind of translate it and really realize, like, that's not going to work at all. And actually developing the Renew app, was planning to partner with some people that wanted to use prolonged exposure therapy, which is a great treatment for PTSD, and wanted to have an app that was PE, and it like walked people, was like, had, fidelity to the treatment protocol. And yes, I just to kind of echo what you said, like, that model is not going to work, because nobody is going to, sit in front of their phone for 60 minutes or 90 minutes. And so it was an interesting challenge to think about. Again, I did want to use exposure therapy, because I think that's I'm a big believer of that as a powerful therapeutic approach. So I was thinking about how to translate that into something that is going to be acceptable in an app format, and how do we break it down, and how do we make it bite-sized, and how do we make it possible? So yeah, I think that's a really important point.
Yeah, and I would reiterate that the work that we've done around how do you take Socratic dialogue, right, which is a really powerful therapeutic tool to create new understanding, and how do we have people interact with the device in a way that might pull that new learning from them. It's not the same as having a conversation with a therapist.
Yeah, and I'll just build on that as well, that, you talk, Zach, at the top about the idea of, that we've got to increase accessibility to treatments. And, the fact is, though, that we've got a real conundrum there, because we have these treatments that are very empirically supported, and yet most contexts where we have dramatically increased access to them has resulted in absolutely no change to the public burden of mental health problems. And there's many examples of this around the world, but one that I'm very familiar with is in Australia, where there was a huge investment in increasing access to psychotherapy through the single payer healthcare system. And now the epidemiological data, that's been going on for probably about 12, 15 years now. And it's had absolutely no benefit in terms of reducing the public burden of mental health care. And it's all meant to be providing evidence-based treatment. So here's the thing, one of the opportunities, going back to David's theme with digital and the issue of personalization, is to be able to do the personalization in a kind of a consistent and principled way. There's a kind of a weird conundrum there. We're personalizing, but in a consistent way. And to actually build a methodology around that can be interrogated and reproduced. Because the fact is that all psychotherapists or behavioral interventionists personalize their treatment. But how do they do it? Do they do it, often it really just involves going off manual for some reason. And, it could be a very well-founded reason, or it could be something, an idiosyncratic matter of judgment and so forth. And so it's this implementation. You've got to get the implementation right and then scale. But if you start with the scale and the access, then you may be scaling something that really isn't going to have a big impact. And that's the opportunity with digital, is maybe to deal with some of those implementation issues.
Yeah, I was just going to add, like, building on what Nick talked about, I can imagine in addition to having the system, which is learned from a well-curated set of data, that it actually continue to learn, right, from the interactions with the user. And then basically you get more enhanced personalization based on better outcomes for that individual patient or client. And I think there are a lot of really interesting methodological ways that people are approaching that by looking at, looking at EMA data and doing network control theory-based analysis of EMA data to figure out for an individual person that if you move the needle on sleep, everything else gets better and the patient is more stable. Or if you move the needle on activity, that's the key node in their symptom network that needs to be manipulated. So I think there are a lot of exciting ways that people are looking at this kind of digitally acquired data to make those personalizations.
This has been really a fun series of talks. I think one of the things that I kind of also highlighting some of the unique elements of digital, kind of building on this, is we can systematically collect these data that really are hard to capture otherwise in kind of traditional formats in that same way. We can standardize it in ways that we couldn't before to iteratively improve things across any of the work that anyone talked about. In a way, it's just like, it's going to be progressively better. It's not going to like experience the setbacks that you might otherwise in trying to maybe catch, like in a hiring of a psychotherapy practice, trying to make sure that your psychotherapists are really delivering the, like the monitoring is so much easier to do in a way that allows you to build up. But the other thing that I think is really nice about these digital approaches is they are operating within the context of daily life. And like Zach, I think going back to one of the slides that you started talking with, is there are so many ways to personalize. And I think that there are a lot of different promising directions to go. We're experimenting with multiple of these things: timing, delivery, types of intervention, style of intervention, content, and they're probably all promising. I don't know that like one is going to get us everywhere for all people. And so I think it's phenomenal that everyone here is working on different aspects of personalization, and that they all probably get us closer to the end goal that we want.
Yeah, I agree with that. And I think that to other Nick's point, I think there are going to be some places where we're going to need that sort of data-driven approach to personalization, where we want the feedback on how this versus that drives engagement, and to inform the personalization, we need that. We can't build it de novo. We need to observe something and then make the personalization based on that. And there are other places where we just don't, because personalization can be conceptualized in different ways. So if you have an app for perinatal depression, and it's delivering some intervention and is using examples, and the mother has the child prenatal versus postnatal, you want to use different examples there. And you don't need like randomized outcomes to say, okay, use different examples now, but that would make the intervention more effective if they're talking about things that are relevant. And as these interventions get used more transdiagnostically and in more complex scenarios, they need to be more adaptive in that way. And some of those things are going to require data-driven approaches and some aren't. And I think they all have the potential to be effective.
Yeah, and I also wonder, like, if there are, kind of the limits of personalization, because I mean, I think I think for, and, it's been interesting because each of us is like in a really different area. So the problems that we're solving are trying to solve are really different. But so we like Carmen did a study on PTSD. We've done depression and anxiety. So we're looking at sort of different different diagnostic categories. And I feel like, in a way, when we're talking about digital interventions, that's a pretty useless tool. I mean, the diagnostic categories are already, not great. But when we're talking about interactions with technology, there's a whole different category of sort of, let's say, diagnoses or prognostic indicators. Like, so for Carmen, you had, for the people that actually engaged in a certain way with your app, they did really well. And for people that didn't engage in that way, they didn't do that well. And so, are you developing an app for PTSD or an app for people who engage with the app in a certain way? So we're not going to create a tool that's good for everybody. And the way that we slice the population is probably not based on a DSM diagnosis. It probably also includes kind of how people's preferences for how they interact with technologies and their, I think personalization, we also have to kind of think of it, for some of the work that we're doing, what are the constraints in that? For whom are we personalizing? Like in this study that I described, we're looking at young adults, 18 to 24, because, we really wanted to constrain the amount of variability in how people are interacting with the tools, because somebody who's 60 is going to interact likely very differently. And that may or may not be the right way to cut it, but it's starting to look at, trying to look at a population, not just from a diagnostic perspective, but from, how they interact with the technologies.
I'll bring a question from the Slack in here that I think is relevant. So you make a great point about people who engage versus not. One of the concerns that I think come up here in a general and specific way, the people who are going to be engaging in clinical trials of digital mental health tools might be different than the people who would be exposed to them at a more sort of population-based implementation level. And so if we build data-driven models from a very unique population, whatever that is, will they generalize? Will they work for these larger populations? And the question in the chat was about, to what extent have any and all of you considered diversity, equity, and inclusion, and sort of the samples in which we're developing these approaches and the data we're collecting? So if anybody wants to speak on that, I already linked a recent review by colleagues at UCLA on this topic in digital mental health, but would love to hear from anybody on the panel.
Well, go ahead.
I was going to say, in our studies, we've made sure that, our participant pool reflects, the folks that we treat around the city of Chicago. So it's a very diverse and representative population. That's one of the nice things about being in an academic medical center in a large city, where you can draw from folks from a wide variety of backgrounds to do your research.
Yeah, I think I think there's two issues you're raising, Zach. I mean, one is the problem of clinical trials to efficacy, and the other is that making sure that we are inclusive. The first issue, I think, is a huge problem. That people who are willing to go through all of the crap, excuse me, that we put them through to get into a clinical trial are not normal people, right? They're demonstrating a high level of motivation just to get to the point that they start, and so they are not normal. And so one of the things that we're trying to do as much as we can is move things out and work work in real world contexts and try to get things approved as quality improvement studies, not as trials, so that we lower the barriers to beginning to use them. That's what we're trying to get through working with MHA, so that we're not consenting people. We're getting the engagement from the users, because there is a huge voltage drop when you go from a clinical trial to real world deployment, because research subjects are not, quote unquote, not real people, not to disparage our research subjects. And I think the issue of diversity and including, that we certainly also try to bring in, a diverse range of people, but there are a lot of challenges there, because that, you know, the way that we as researchers think about diversity and inclusion is really gross categories of race and ethnicity. And I don't, you know, I mean, certainly those are meaningful in our country, but they, you know, those categories, there is more variability within those categories than there is between, and I don't mean to diminish that, but just you know, I think you know, older, you know, there are differences between races and ethnicities, but there are differences between young people and old people. There are, and this problem of heterogeneity that we have, you know, across people is huge, and a huge problem for personalization. So, you know, certainly race and ethnicity is something that we are trying to use to tailor messages. And you know, we know that people want interventions that speak to them in the language that they use, not just whether it's English or Spanish, but in the way in which they use language. We know that they want to see things that reflect them. So that's important, but I think those kinds of things are one level, and there are a lot of other levels and differences within those communities that also are important.
I just have a follow-up on whether, though, if somebody's interacting with a therapy chatbot, do they have those same expectations that they would have of a human therapist, right? If they come in with certain expectations, knowing that they're interacting with technology, might some of those expectations be mitigated?
For us, I mean, we try to preempt that specifically and say occasionally it's going to say nonsensical or clunky things. I mean, as close as we are, as good as these models are, they are not humans, and they will eventually reveal themselves in some way, shape, or form. They will convince, kind of mix up I and you, and kind of it's almost like you're speaking with someone sometimes who like has a language difficulty, like it's not their first language, but they get kind of things mixed up and jumbled occasionally, even among the very best performing chatbots within dialogues. So yeah, we just try to preempt that by setting the stage of what the expectations are from the user, and that part of why we designed our chat interface to not be a human is to kind of get this like kind of silly, playful kind of tone along the way, even while they're discussing it, these kinds of things, in large part because it's going to mess up and it's going to be imperfect. And that's, we're hoping that that's okay. It's I don't know. I think kind of setting the stage, I think, for what the expectations are really important. And I guess I'm going to like harp back on one statement that's been made about like the decision point between efficacy in our RCTs to like actual full-blown like real world settings. I think one of the ways that we slice the dice in ways that are really not just meeting reality is engagement and how we quantify engagement in real world settings. I've tried to make this argument a few times, but I haven't actually written a paper about it, and I probably should. But one of the ways that people actually use apps is they experiment with them. It's kind of like you walk into a store and you look at something on a shelf and you see, oh, like, if you're in the TV department, do I like how this looks? And folks do that with the applications. They keep them, they start with them, they see if they like the interface, is it doing what they hope it to do? And those persons that are sampling are counted as users. And I don't think they should be. I don't think they're actually intending to long-term use this app necessarily. They haven't made that commitment. They're just browsing. And I think actually the numbers look a lot better if you look at folks that stay in and get in the door and actually intend to use the app. So like, I don't know how different they end up being from our RCTs. We certainly have these pipelines of ways to make sure that folks are committed. But once folks are committed, I actually think they're not all that different of populations.
I think it probably depends too on the nature of the clinical trial and the procedures. You know, I think if you're setting it up so that there's this like there's diagnostic interviews that they have to do, and this huge assessment battery, and there's this consent, and there's this orientation, and they're also too, if they're getting, kind of any kind of support or reminders from research staff to kind of keep them going and keep them engaged, if they're being, compensated for participating in the intervention or for the assessment component, all of those things I think can skew the research sample away from kind of the target population. And I can give an example of that happening on steroids from my own personal work, where I did a study of a web program for PTSD, and I wanted to compare it to in-person psychotherapy. And 10 years ago, that seemed like a really good idea because I wanted to see how it matched up to kind of a gold standard modality. And I really could not recruit for that study. Turns out people that want to do web programs at home for PTSD aren't the same people that also want to be or willing to be randomized to in-person psychotherapy. And also not a good idea to require both groups of people to have to come in for in-person diagnostic interviews and assessments and so on. So, I share this because I, learned from that mistake. But, I think if you're making the assessment battery really minimal, you're thinking about the burden, you're thinking about all of those things, you're better positioning yourself to kind of really gauge what the potential impact could be in the real world.
Thank you.
Can I chime in?
Yeah, please.
The one other thing that I wanted to add is there also are apps and projects that are flipping how we're approaching data collection. So Shannon and mine, it's not a clinical trial. It's actually an implementation project to address an immediate need. We are collecting data. We'll be looking at that data to learn from it around personalization, and then we'll be submitting a clinical trial to evaluate it. Right? The PTSD coach is a great example. It was put out in the real world. Now people are doing really high quality studies to see how it works. So that way you're actually developing the program with real people in a real world setting. So that's another model that we can consider.
So thank you, Deborah. And I think that echoes what David has said. And I know that others of you on this panel have done that. We're wrapping up, so I'll make one last plug, and then I'll ask if anybody has any concluding remarks that they want to make. Ron Kessler has advocated for that same iterative approach for predictive model development and evaluation in the context of personalization, where you use large naturalistic data sets to develop models, and then you test them, evaluate them in small focused clinical trials. And I think that same thing is relevant here for the development of digital mental health, as well as personalization approaches in the context of digital mental health. So just really would love to just sit with all of you for another few days and listen to you talk, but we have only a few minutes left and supposed to turn it over with a minute to spare. So does anybody have sage additional remarks about where we need to go with this work?
Keep doing your stuff. I really think everyone's making individual contributions in unique ways that hopefully will move the field forward, and I really like hearing about it. So thank you all for doing the work, and thanks, Zach, for organizing this panel.
Right.
I'll say that I got into digital mental health about 3 years ago, and so many people on this panel, I just came to them and said, please help me understand what's going on. And so when I hear all of your great work, I'm like, oh, hey, we're doing that. And then I realized that it's because all of you told me what to do. So it's really such an honor to be learning the new things that you're working on. And as Nick said, keep doing this fantastic work, because together we'll move it in the right direction. So thank you. And I'll turn it back over to the crew.